My name's Steve Gardner. I'm the Managing Director at Healthcare World, and I'm joined this morning by a fantastic panel of experts to talk about what I think is probably the most exciting healthcare opportunity in the world. Saudi Arabia, we've been engaged now with it for the last year or so. We'll be media partners again at Global Health in Riyadh next week. And ahead of that, wanted to have a look at what's going on in the kingdom. Really, I think there are two massive opportunities in healthcare in Saudi. Firstly, you have a situation where the public health system is being completely reformed pretty much from scratch to create what will at least initially be a free at the point of delivery healthcare system, which then morphs into a national insurance program, and something which the Saudis are working really hard to get right, looking at models from around the world, from the NHS, from the US, and from around the world to ensure they're getting the right healthcare system in place. And we'll discuss that in detail. There are also huge opportunities in the private sector. Quite a number of private hospital groups run out of Jeddah, as well as, of course, the mega project that is Neom, which will have its own health system and its own health insurance system. And we'll hear a great deal more about that as we go along this morning, as we're very pleased to be joined by the sector head for health and wellbeing, Mahmood Al-Yamani. As well as Mahmood, I'm joined by Mohammed Al-Dar, Chief Executive Acumed, the largest revenue cycle management consultancy in Saudi, and a very well-connected individual and organisation in the Saudi public health system. I'm also joined by Steve Moore, who until recently spent 4 years as a subject matter expert at the Health Holding Company in Saudi Arabia, and can give us an insight into his time there, as well as his new role as head of healthcare for Maximus Gulf. I'm joined by Jennifer Nobbs of Beantree, a leading UK-Australian data firm who are doing work in the kingdom, and Gerard Hanratty from Lawyers Brown Jacobson, who've been working on some of the founding law for Neom. Welcome to all of you. I think where I'd like to start this morning is just give me, each of you in turn, your thoughts in terms of what is it that makes the Saudi healthcare opportunity such a big and important one globally. Perhaps, Steve, as somebody who was steeped particularly in the public sector transformation, we can start with you.
Thanks, Steve. Yeah, good morning, everyone. Yeah, it's a really exciting time, isn't it, in Saudi Arabia and healthcare. If I take a step back, though, first of all, and think about putting health in context, as you said about Vision 2030, the positive energy in Saudi Arabia broadly is incredible. I'm hearing stories of Saudis who have lived abroad for years and years. They're all coming back now to get a part of this. We're talking about nation building, aren't we? And health is absolutely a key cornerstone of that vision. For those new on the call, we're talking about a new vision, a new strategy led by strong clinical leadership. We're building up core capabilities in population health management, care delivery, new models of care, all moving towards a value-based care system and better financial sustainability, all of which is being underpinned by better e-health and digital, better upskilling of the existing workforce, and just really truly effective relationships and partnerships between the public and private partners. For me, it's what's not exciting about healthcare in Saudi right now.
Mahmood, you, of course, you have a foot in both camps because you serve on the boards of the Northern and Western business units on the public health side, and of course you have the head of healthcare position at Neom. What for you is exciting about what's happening in Saudi and healthcare right now?
I guess I wear two different hats here, and I see the excitement under both hats. As far as the public healthcare system transformation is concerned, we're actually transforming healthcare in the three domains: the provision, the monitoring, and governance, as well as the payment system. And that is a tremendous amount of transformation that happens at the same time on three different parallel fronts. And that by itself is exciting because it's all being built on two main fundamentals: population health and digitization of as much as possible, and then building the platform that will integrate all of these digital files across the whole country, not only within clusters of healthcare, but also across clusters, so that allows the citizen and or the resident of Saudi Arabia to move seamlessly and have their health profile be along with them wherever they are. Now, the main focus, to be honest, is on quality of care and sustainability and cost, as we have noticed that cost has been increasing significantly over the past 3 decades, with an increment of about 7% annual cumulative annual growth increment in the budgets of healthcare spent by the public sector, i.e. the Ministry of Finance, and that has called for this total reformat, because as the spend has been increasing, the satisfaction has not been increasing as much, in fact declining rather, and then the focus on primary care has been totally missing. So that was the call for reforming the entire healthcare system. Now, as far as Neom is concerned, we're looking at this from a different perspective. We're actually looking at building a healthcare system that is individualized. So we're not even looking at populations anymore. Our population is basically each individual by him or herself. And then we're building that the relevant information around each individual, again, on a huge platform that would use artificial intelligence to be able to predict all possible things that could happen to a human being from their inception until the end of life, aiming at increasing the life expectancy at birth, adding more happy, healthy years of life to people at their advanced age, so that the cumulative effect of their economic contribution is maximized. The second element to that is building a biotech ecosystem that again enhances these areas of interest of Neom, which is personalized preventative care, the focus on diseases, specifically on diabetes and metabolism, since that is one of the main, these are one of the main factors that lead to advanced aging and stuff. And then we have the musculoskeletal disorders, because as people age, they tend to have a lot of more and more musculoskeletal disorders. So we want to come at that concept of longevity from all aspects of it. Parallel to that, we're building a health provision ecosystem, again, at a cutting edge technology. And based on the fact that we are preventing a lot of diseases by digitizing health and by using artificial intelligence to reduce the burden on clinical facilities, we're reducing the infrastructure. We're proposing to reduce the infrastructure by about 50% of what normally is required.
As Steve said, and I'll borrow his phrase, what's not to be excited about? Thank you very much for a really good overview. We'll delve deeper into both sides of that point later on in the discussion. Mohammed, you've been involved in both sides also as a supplier of the transformation of healthcare in Saudi Arabia. What's your view?
Thank you, Steve. Actually, I'll quote the vision from the Crown Prince, Prince Mohammed bin Salman. His statement is exactly, and I'm quoting his sentence: "The future of the kingdom is one of the great promise and potential. Our precious country deserves more than it has achieved. Therefore, we will expand and develop our talents and capabilities to craft this future." And I think what is unique about the kingdom now is having one direction vision, where we know exactly what we want to head to. So, like for example, in health transformation, Dr. Mahmoud and, like Steve just talking about improving the quality of efficiency of healthcare, promoting the prevention side of healthcare. It's called usually healthcare, but we usually, paid attention to the diseases and sickness, but never paid attention maybe enough to the prevention side. I assure you that, building up the national healthcare system was based on identifying the major 8 challenges in the vision. And here talking about, first of all, talking about like the premature. So we are like 5.2 years below the life expectancy that's been declared worldwide. And that's what that was like challenge number 1. Number 2, talking about like what just Dr. Mahmoud just mentioned, we have like more than 4.6 millions of the population having diabetes, and this is expected to be doubled by 2030. The problem with the road traffic accidents and the mortalities related to that, aging of the population. That so we are heading to, currently we are more than 33 million population in Saudi, and this is like expected to be around 72 by 2050. Talking about the to address again the prevention and introducing the telehealth and the home health care in Saudi Arabia is something also was really very well needed. So talking about all of this into like sort of an ecosystem to build up the national healthcare system to achieve the effective and sustainable financial resources, where RCM and where I'm leading Acumed in, is to provide the solutions to the market, especially when we are talking here about the public sector, as part of the transformation to find out the right sustainable financial resources to support all of that. Thank you, Steve.
Thanks for that. Jennifer, coming to you next, from the outside looking in, as an international organisation that's worked in markets all over the world, what attracts you to Saudi and the Saudi market?
Well, I think to again pick up on Steve's point earlier, the thing that seems to attract everybody is when you first look at it is the scale and the enthusiasm and the ambition and the commitment to a real vision of the whole country, and that remains throughout the whole thing. It's infectious, but when you start to dig into it, you realise that the systemic change that's being delivered is evidence-based. It's done afresh without the need to tweak with complex, long-established systems where when you pick at something here, it unravels elsewhere. So the opportunity to lead on, really exciting, innovative approaches is just amazing. And there's huge attention being paid to the experience of other countries, as you said, borrowing from the US, the UK, and so on. But in doing so, it's not picking up a proposal from elsewhere and putting it in, as must have happened in many countries in the past. But what strikes me now in Saudi is the desire to make those changes from within Saudi, with Saudi people leading the way and bringing their experience and the importance of those sorts of things. So to play a part of that as an expert in a field where I can lend expertise and experience is a brilliant opportunity and feels like a real privilege.
Gerard, finally to you on this point, what attracts you to the Saudi market?
So I think from a legal perspective, which may be a little bit geeky, you rarely get to go into a system where you can develop from the ground up. So it's a greenfield site in terms of developing the legislation. Most of the time what we are doing is we are amending laws. I mean, if you look at the UK, the NHS Act is from 2006 and we've amended it God knows how many times. And so, you're always doing that. And equally, you're always looking at curative healthcare. So we don't really have the ability to stand back and look at how do you design and create a preventative healthcare system that is hugely beneficial to all of the population. Whereas certainly the work we're doing in Neom, well, from a legal perspective, it's just amazing because you're in there. First off, you get to do benchmarking across the world. Now, I probably shouldn't say this when Mahmoud's on the call, but rarely as a lawyer are you paid to actually look at all the different healthcare systems and then say, look, this is how we can bring these different elements together and really start to make this look like something different and something whereby you're incentivizing your citizens to get behind the concept of preventative medicine. So you're actually saying to them, work with us, let's do this, let's evolve, let's try to avoid having to go down the curative route and trying to always backtrack to try and get prevention. Let's actually go straight there. And that, you know, in developing those laws, it's very different to what we've done elsewhere. And, you know, I've worked in the UK, we do stuff in Europe and look at those, but Neom is very different from that perspective. And I think the kind of almost the joint agreement between the state and between the citizens in order to push forward prevention rather than looking to deal with sick care is hugely exciting and very different, as I said, to anything else we're really seeing around the world at the minute.
No, thanks for that. And I want to echo that sentiment, actually. And the thing that attracted me to Saudi, as somebody who has been described as a health systems geek, is literally the geekery of it. It's the fact of, you know, where else in the world do you get to answer that question of, you know, if you were going to design a healthcare system from scratch in the 21st century, if you were going to make it digitally and data enabled, how would you go about it? And actually, you know, in both public and private sector, you know, you've got ambition on both sides of the coin to create a really advanced system, and to look at all of the best examples in the world and see how you would implement them. So yeah, it's a fascinating market. It's a fascinating opportunity. And the other thing I've found, couple of small points as a Brit going into Saudi, and Jennifer, I want to ask your experience here as well. Culturally, the country is fantastic. I mean, for a start, what I've found in my travels to Saudi Arabia is there is no other market in the world where the people are as willing to listen, and as interested in understanding what examples and what things are going on in other parts of the world. I think as a traveller going to Saudi Arabia, I found it very, very welcoming. I think sometimes the global media gets a little bit overexcited about Saudi Arabia, and my lived experience has been that it's been a really great country to travel to. Jennifer, as a woman traveling to Saudi Arabia, how have you found it?
Yeah, I couldn't agree more. I think there's assumptions made about what it's like to travel to Saudi that are quickly debunked when you visit. I really enjoy, I travel to Saudi every month and I really enjoy it. The people that I work with and the warmth with which I'm greeted is like nothing else, and the enthusiasm to have a conversation and to throw around ideas and to reflect on changes happening in Saudi and the rest of the world. It's a great environment to travel to, and wonderful people to work with.
So there's a myth debunked nice and early in the conversation for our international audience. I want to go on to talk in a little bit more detail about specifically the public sector development. We'll go on to talk about Neom and the private sector a little bit later in the conversation. I wonder, Mahmood, as somebody who sits on a couple of the boards, where you could just give us an overview of the current status of the transformation. Where are we up to? What's happened to date? What happens next?
The health transformation program was basically built around identifying what would bring these clusters of networks of healthcare providers together. And it started by basically implementing a model of care even before changing the governance of these entities. And the idea was that we want to see who in these entities would be interested to work together on a different delivery model. And then based on the outcome of that, the governance would be changed, i.e. we will be building these clusters around an anchor asset, be it a tertiary or quaternary care hospital, and then with a number of primary care and secondary care hospitals so that they can create a seamless journey for the clients and focus on the areas that need improvement. And so that was step number one in the process. And then the second step was, now that we have identified groups and we've called these the pioneers of health clusters, how do we spread that idea around? And then how do we focus on defined populations? And so we moved from aligning providers to work together to now identifying populations. And then by building the knowledge about that population, we would identify where do we need to focus in the delivery arm. Now, all of this has been happening while another group was looking at how do we change the payment system so that instead of it being a block fund and spend as much as you can, to rather redirect money to where it's needed and be able to be agile in spending as long as you are as long as you're creating an enough impact of the dollar and creating an enough creating a service that is sustainable and based on best possible outcomes for the interventions made. And so these were the kind of the two layers to start with. We have almost completed these two, and now we are into the phase of writing the governance of how these entities are going to be managed from a cost and revenue point of view, and at what point are they going to be spinning off as non-for-profit, semi-private, government-owned companies. And so they function under the regulations and the laws of the labor law and the private sector law, but they are non-for-profit and they're owned by the government. It's a tremendous journey, and it's been going on since 2014, 2015 to be precise, and it still has another decade for it to bring out fruits.
So Steve, I want to go on to you next, and let's look at two sides of what Mahmoud's talked about here in terms of the structural elements. There are two elements, aren't there, in terms of the provider side, which is the health holding company, and the future payer side, which is the under the CNHI, which Mohammed, from a revenue cycle point of view, you can talk about. Steve, you've been involved in putting the provider structures aside in your time at health holding companies. You first explain what the health holding company is, where that fits in the kind of organogram, and then the kind of clusters that Mahmoud was talking about.
Yeah, sure. So again, let's start by taking a step back and think about the Ministry of Health. Currently, or historically, traditionally, it's done all of the three things that Mahmoud's talked about and others. It's being the provider, the payer, and the regulator. So the transformation program is around breaking that up a little bit. So the Ministry of Health becomes a pure regulator. Two new entities have been created: Health Holding Company that will look after provision, as you've said, CNHI looking after the payer functions. So there's approximately, I always round up, there's approximately 300 hospitals, 2,500 or so health centers around the kingdom. And those have been divided up, as Mahmoud said, into clusters, which are going through a transformation journey, which will ultimately become accountable care organizations. At the minute, we're targeting around 20 of those across the kingdom. And this is going to be new C-suites, new boards, new everything. This is the mechanism. And a health holding company is the one, through its mandate, to try and manage and be responsible for that transformation and be responsible for that provider. I think there's still discussions going on about what that really looks like in terms of, is that a contractual agreement with the Ministry of Health, or what does that, what are the nuances of that? I'll leave that to the legal teams to sort out. But ultimately, Health Holding Company is there to upskill, provide guidance, to sort of act as the front of house for the whole transformation on the provider side.
So, and Mahmoud, I understand you're on the northern and western boards. So the boards, as I understand it, you have a group of clusters that report to each individual board. Is that correct? Correct.
It actually started with the pioneer boards, the first 5 boards, and then the next group of boards, up until about 12 boards, where every cluster had its own board. And then this was again redesigned, where every 4 to 5 clusters in a major region are under one board in a transition period until enough boards can be developed over the next decade. So it's a kind of an interim state right now.
So the intention ultimately is what? That each of the 21 clusters will be self-governing with its own funding mechanism.
Absolutely, and then spinning these off as standalone entities. Every cluster will be an accountable care organization for roughly about 1 million plus or minus. And then all of these clusters will be eventually reporting to individual boards. And then these boards are all under the umbrella of the health holding company. And then once they mature as a standalone accountable care organization, the health holding company will vanish.
And how many of these clusters are operating so far? What stage are we at in terms of the development of the clusters?
there are three groups of clusters. There are the early clusters, the first five, who are about to graduate so that they move from the ownership of the Ministry of Health to the ownership of the health holding company within a year time. And then there is the second group of another 5 clusters that are about 2 years away from this step. And then there is the third group, which is the remaining of the 20, that will probably be there in about 3 years' time.
So which can you detail for us, which are the 5 that are coming into existence at the moment?
E1, the Eastern Province, the 2 clusters in the middle region, Riyadh and Qasim, the Mecca cluster, and these are the first 4, 5, and then Medina and Medina cluster.
Medina as the 5th one. So again, coming to you, Jennifer, as somebody who's looking to work in the kingdom, what's your experience been of what level of this system is it kind of best to approach and best to talk to?
I think it really depends on where that part of the system is in its transformation journey. So Beamtree have done a lot of work at a central level with CNHI and the Case Mix Centre, NHIC, HealthCo, CHI, and so on, lots of acronyms. And that's been really good in terms of understanding policy intent and ensuring rationalisation of data and quality assurance across the kingdom, and spreading information and supporting those agencies in delivering their message across the clusters and so on.
So I'm going to take you to task a little bit on your acronyms, because I think it's important for those watching that we understand what these organisations are and where they fit into the system. So you mentioned CHI. Who is CHI? So
there's CNHI and CHI.
Yeah,
essentially, the public and the private payers is probably the simplest way. I mean, that skims over some stuff, but the simplest way to explain it. So the Centre for National Health Insurance and the Council for Health Insurance, public and private respectively. And we've worked with both, looking at data quality submitted by hospitals and setting the standards for those as well, which means that there is an increasing reliance on data to make decisions, as you can start to trust that data more. But then there is also a requirement to ensure that that data is accurate and complete and properly describes the care being provided to Saudis, for the reasons that others have mentioned around population health, chronic disease, and so on. If the data doesn't reflect what's happening to a person, then you can't prioritize resources appropriately. So that comes from a central level, but if the workforce isn't there at the hospital level or the cluster level to support those changes, then they're ineffective changes. So it requires engagement at both points.
Yeah, and I think that's going to bring us onto the payer side in a moment. I think sticking with the delivery end of things for a moment, Gerard, I mean, this structure is not unfamiliar to us in the UK, because ultimately, clusters, are they the same thing that in the UK we would see as ICBs or integrated care boards? How does as somebody who's worked in the UK system and worked in the Saudi system, give me a little bit of comparison between the two.
So I think one of the things with the Saudi system is that it's a bit easier to navigate, to be honest, and to understand. And I say that because one of the things that has happened, certainly within the UK, is that we have layered governance on top of governance. And so what we are trying to do to create integrated care systems is unpick a lot of that. So with the recent changes, we've moved from what was a competitive system to a collaborative system, which is focused on integrated care. That's a big cultural shift, but it's also a big governance shift. And the way that your data flows is quite important as well. We also have quite a lot of red tape, to be honest, around the way that certainly our patient data flows. And we need to remove some of that, especially, to be honest, as the UK moves more into the international arena and starts working with other organizations. So, exchanging information and data on things like genomics and how, cancer treatments may operate and what you may do with it. It can be a little bit difficult at times to do that. But I think when you then go back and you peel away the governance around integrated care systems, one of the things that I keep talking to certainly our clients in the UK about is, how do you actually achieve the integrated care? And some of them look at me like, I'm a little bit mad. What am I talking about? That's what I'm creating. But it's about how do you make sure the patient gets the integrated care, not how do I create mechanisms by which organizations talk to each other. How do I take that one step further and then make sure that the cluster or the ICB is actually getting the patient the care they want, so that that is integrated, because that to me is what integrated care is actually about. And that's the more difficult bit. And I think all of us are just kind of looking at that. So we do look at what's happening in Saudi Arabia in order to see what we can borrow from them. I know they look at what we're doing, and we do that benchmarking around the world to see how do we actually make this work, and make sure the patient gets the benefit.
I think it's a really interesting, the point about integrated care is a really interesting one. And I think it speaks to a broader point that again excites me about the whole development of healthcare in Saudi. I remember once describing integrated care as being a bit like the idea that you can dig up the road and put in the water pipes, the electricity, the broadband all at the same time, and just dig one hole. Do it all in one go and sort it out. I think the issue has always been in not just the UK, but also the other more mature health economies that I visit, is that there are Chinese walls between, sometimes brick walls, never mind Chinese walls, between primary care, acute care, mental health, community care, elder care, etc., etc. The beauty of Saudi Arabia is that rather than forcing a group of existing organizations to work together and start to integrate, the whole system is built around the idea that your healthcare is integrated and all these bits of the system look after you in a kind of seamless way. Mohammed, we'll go on to talk about the revenue side of things and the payer side of things and how that will evolve later. But what's been your experience of the way in which the public system has developed over the last nearly 10 years now, I guess?
First of all, I would like to emphasize on the fact that in Saudi Arabia, we had a couple of very successful experiences. However, they were scattered. So for example, and today, Dr. Mahmoud, he mentioned about like building up an ecosystem for a cluster, like making sure that the primary level working with the secondary and then tertiary and maybe whatsoever higher than even tertiary. But then, so we had, for example, a very successful experience when it comes to King Fahd Medical City and Riyadh, or King Faisal Specialist Hospital, which is ranked number 20 worldwide. And, you know, like when it comes, for example, for primary, you have like an excellent experience in Johns Hopkins, Saudi Aramco, but then making sure that all those experiences are working together the best and learning out of maybe I would say the local way. So we try to learn out of what are the other countries are implementing and applying today, and maybe adopting them the way that we think they are fit into our needs in Saudi Arabia. What has happened during, so while clusters started to formulate, CHI was there for the last 24 years now. And, you know, like the first policy in private sector, the first health insurance policy started in Saudi Arabia as a mandatory.
Just to be clear for our audience,
2000.
CHI is the kind of the trade body, if you like, for private insurers, isn't it? Just want to make sure we clarify.
Yes,
that.
it's the Council of Health Insurance, so it is the sole regulator for all whatsoever related to health insurance. And there is also an update that I want to also to talk about in a while about the Council of Health Insurance, because there is also, maybe everybody heard about the new authority that will be already activated in 1 month's time. That is the Authority for Insurance in Saudi Arabia. So that's also another important update. So let me just to highlight a few points here. So when it comes to health insurance, for example, today we have more than 11.5 million insured members in Saudi Arabia, but these are like majority coming, so less than 500,000 coming from the governmental sector for some ministries and some authorities, but then the majority 11 million coming from the private sector. So that started at the very beginning, Steve, and all the audience started with very minimal number, where the compulsory coverage of health insurance was starting back in 2005. So it was not mandatory in that time. And there are a couple of achievements being happening, actually, not only on the number of the growth of the total number of members, but also on the benefit provided. So currently, if you compare today to 20 years back, you will find that today health insurance policy, the mandatory one, covering huge benefits when it comes to, for example, prevention. That was not there at the beginning. CHI, the Council for Health Insurance, the regulator for health insurance in Saudi Arabia, also took a couple of points with regards to the, because data is, like important in all what we are talking about today. And like a few years back, we could not talk the same language. So we were talking, so different institutions, healthcare institutions, we're talking different languages to each other. So it was not unified. Today we have unified classification systems for diseases, for example, for services provided to patients. So usually you can gauge and measure what you are providing, and you can issue statistics where you can come up with good conclusions. What are the deficiencies and the lacks that you need to really optimize and make sure that you start to fill in. And today we are talking about digitalization. So first time ever, we have today what is like the data bus between the hospitals and the payers, which is called Nafis. So Nafis in Saudi Arabia is connecting payers with providers, making sure that all the data whatsoever provided to a patient has been transferred. It started as an idea to transfer only the claims or invoices, but today, and there will be soon a great announcement during the GHE, it will for the first time ever introducing the unified file for patients. So a patient who is visiting X hospital, the doctor in Y hospital will be able also to access those clinical details. So we will start to see some, some exchange of data at differently considering all the confidentiality and all the privacy related to that. What I'm trying to say here is that in order to create a sustainable financial resources, there are a couple of steps has been taken in order to support that. Part of it actually, as a revenue cycle management companies, the first ever legislation licensing such companies in Saudi Arabia was only in 2020. So before that, we didn't have any, I would say, regulation offering the license for such service. And that's why today we believe that the change happening is also to support a very important pillar, which is actually building up sustainable financial resources for all the vision coming. When it comes back, if I want to go back to the authority for insurance, actually this is something that has been just released by a royal decree, and today there will be today the overall insurance, whether it's health insurance, motor insurance, and any other type of insurances, are actually so 60% of today portfolio overall is coming from health insurance, and many others are not actually considered today even to be covered internally. So that's why the authority for insurance came today in order to give a deeper insight for all the insurance market and widening. So today, if we are talking about, 0.2% of the GDP coming from insurance, that was like 3-4 years back. Today, we are at 0.77% of the GDP. And in 2030, we are heading to 2% of the GDP coming from the insurance industry. And that's why these initiatives are all taken care in order to achieve that goal.
So, Steve, just come to you on this point. Actually, no, Mahmood first, and then Steve. The intention, as I understand it, listening to what Mohammed said there, in terms of the journey of public health for every citizen as an observer of Saudi Arabia, am I right in thinking that initially we start here with a free at the point of delivery system? So we're going to start with a system where healthcare is funded by the state, and then CNHI has been set up to move that away from that initial free at the point of delivery system towards a national insurance system. Steve or Mahmood, do you want to come in on that point and just confirm or deny that for me?
Go ahead, Steve.
Thanks, Doctor. Thank you for putting that one on me, Steve.
Anytime.
I think the most diplomatic answer that can be said right now, it's currently being worked through. I think the mandate for CNHI was just announced last year. I understand that the bylaws for CNHI are in the middle of being formalized and approved. I think that's going through recently. So I think you're broadly right on your assumptions, but along with the new strategy refresh that's coming out from the provider side that is currently being conducted now as well, I think maybe early next year we will have a bit more clarity on that direction.
So Mahmood, if as a Saudi citizen I fall over and break my leg right now, and I go to a government hospital or a government facility to be treated, is it a question of that I would be treated on a free of charge basis, or would I be given a bill? Would I have to have insurance to be treated? How does it work right now?
As an interim solution now to the two entities between public and private, the public entities are entitled to charge your insurance company if you're insured. If you're not, then you're under the public coverage side. And that applies to Saudis or non-Saudis in the region. But that's only in emergency cases. In elective cases, you would want to go back to your insurance companies to seek guidance as to where you're going to get your treatment. But in emergencies, you get treated in the first hospital that receives you, and then a bill is issued to your insurance company.
Right. So at the moment, it's again mostly insured, but with a degree of national government coverage, so to speak. Mohammed, you're the one that's really in the know about how the insurance system is developing. What are the timescales then for moving to that fully national insurance-based system for everybody?
See, I think this is very still at this stage. I don't think that there is like a clear answer to what sort of time frame maybe, but maybe it's more of like talking about what sort of model we are heading to. So talking, for example, about the value-based healthcare, where everybody is starting to set their like all the basics around that. So we are talking here how to optimize our outcomes versus optimize also our cost. And that's why maybe before heading and maybe transforming that to be like totally handled by private, I would say health insurance, maybe some optimizations needs to be taken care of and to take place before making sure that we hand it over to the 100% to the private sector. And that's why maybe, like, as I said, I mean, we didn't have so costing was not there. Today, we started to see some costing and the regulator starting to head with regards to costing and pricing of services. Dr. Mahmoud just mentioned, like, for example, today, if I'm like somebody who is insured, then the governmental sector are entitled to invoice that service to a health insurance company. But those prices being set already by the regulator based on a very detailed analysis about what sort of prices should be provided, making sure that we need also to balance between what is the costing and what is actually, should be charged to a health insurance company. So back to the question, I think it's all like as, so CNHI started to put their, CNHI is the Center for National Health Insurance, where they are actually starting to take over some of the, the payments of the governmental side. Already, I think in the private sector, when it comes to CHI, because of almost 23, 24 years, it's already sort of mature system. It needs definitely some optimization, but it's a mature system today. So I think we will have some sort of maybe, like a balance of both systems in order to make sure that we move all together in one goal.
Gerard, coming to you, how much of this is a legislative and legal challenge approach to actually get the kind of regulatory law and system in place?
I mean, subject to the views of the government, to be honest, you can create all the laws and the regulations. That's not necessarily the difficult bit. Putting them into language that people can understand is important. But then a large part of it, and certainly what we are finding in the UK, and we're also finding in Europe at times, is that when you start to move a system along, relationships are key, especially on integrated care, to making that work. And equally then when you're also looking at insurance-based systems. So I think one of the challenges the insurance companies have presented to some of us when we're looking at this is, what are you talking about when you're talking about a preventative-based policy? What is that? What are you asking us to give you? Because what we're really used to is curative. So we're used to, you have something wrong with you. We are told the cost basically of fixing you or curing you. That's what we're prepared to pay for. We will pay for that episode of care. And if you go past a certain number of cost or a number of treatments, then actually you have to pay for that by yourself. They're used to that. Insurers understand that. It gives some certainty. When you're talking about prevention, when you're saying to them, actually, what we want to do is have a policy here whereby we're looking at people when they're not sick, and we're going to make sure that we keep them not sick, and we're going to treat them, and we're going to start using a whole load of other things like wearables. I mean, from the thing I did last year at Arab Health, wearables is huge in terms of the data it can give you and how it can help you. But I think part of the other issue we're going to have, apart from creating the legal system and getting the relationships, is actually getting the insurers on board with the whole concept of moving what they do from curative to preventative.
It's interesting. I was chairing a panel at Africa Health in Johannesburg last week, where we were talking about the concept of value-based healthcare, and value-based healthcare is clearly something that that panel was quite fascinating. 6 people on the panel, 4 of them were talking about stuff that frankly wasn't value-based healthcare. Value-based healthcare is not an easy concept to get your head around. At the end of the day, it's created by the challenges. You call it curative. I mean, I guess from an insurance point of view, you talk about the idea of volume-based payment models, i.e. the more times I do a thing, the more times I get paid for it, and moving that into a situation of actually we're going to pay for outcomes. And what does an outcome look like? And I don't think anybody's quite cracked value-based healthcare yet.
No, I mean, I'll tell you what was interesting. I mean, this is a few years ago now. We had Google, and they teamed up with the Royal Free over how do you use data to actually prevent somebody having an episode. How do you do that? How is that all working? And you know what? We didn't get hung up on the fact that, isn't this amazing? We can stop somebody having, an ill episode because we can actually see it coming. We can predicting it, which I think Mahmood was talking about earlier about AI and how we can do that. Actually, we got hung up on the fact, well, what are Google going to do with all of this data? This is terrible. Google could be sending it all over, as opposed to just saying, okay, what we need to do is have this quite tight, because this is people's, sensitive personal data. We don't want it to be used all over. But actually, what a huge benefit. And that's some of the things we have as well, that culturally we get hung up on things without actually seeing the wider opportunity that's there. And that happens especially with the law. We fixate on small parts of it without thinking, how do we actually find the solution? Let's not put the barriers in place. Let's create the solutions.
Well, I was talking there about value-based healthcare from the point of view of insurers playing for outcomes and working out what the outcomes are. There's an even bigger one than that, which is actually how does it, and you nodded to this before, how does an insurer pay for no outcome at all, i.e. preventative care that prevents you from needing to enter the hospital system in the first place? Jennifer, you're the data person in the room. And Mahmood, I want to come to you in a minute because I know you've got some really interesting answers to these questions from a Neom point of view. But Jennifer, what's your view on the whole kind of how do you create value-based healthcare in a system like Saudi?
The challenge that is the one that you've pointed out, which is how do you justify a spend for something that you're not measuring in the same way that you would for a hospital service? And it's about connecting the data up. again, to be able to track through not just when somebody gets sick, what happens to them, what happens to the group of people that would have otherwise have got sick, and how do you start to connect information from a broad population and the health of the population through to primary care and secondary care, and how do you start to incentivize other parts of the system, or rather incentivize the transfer of funds from the tertiary sector through to the primary sector through to population health, so that there is not parts of the system pitting themselves against each other, but working as a whole to improve care overall. Because $1 spent in the community is, you know, $5–10 spent in hospital care later on, so saving yourself a lot of money in that process. So it's about automating more data collection to take the impost off broader data collection. So how can we collect information about what's happening to an individual in terms of their general health, in terms of their activity, in a safe and respectful way? How can we take the pressure off primary care to collect information? We've put lots of resources into collecting this sort of data in the hospital setting because it's been easier and we valued it more. We need to start to think about how we can do that in other sectors, and how we can use the technology and the insights and the materials and the tools that we've got now to make that process much easier. And the exciting thing about Saudi is that, to go right back to the beginning of this conversation, the enthusiasm for digitization and for embracing new technology provides an opportunity to really do that.
And I've no doubt, Mahmood, that you're champing at the bit to come in on this point in the conversation, because we did an interview, you and I, a couple of weeks ago, where we talked about the way that Neom is creating its own insurance system, and indeed its own policies as regards wellness and healthcare and the preventative element of healthcare. Do you want to give us a little bit of an insight into what you've got planned there? Because I think it's amazing.
Sure, Steve. But if you allow me to, I'll go back to your previous question on the health insurance regulators back in base economy, that is in Saudi Arabia, and how is that evolving, if the time allows for that?
Yes, of course.
I guess what's going to happen in the near term is that there will be two regulators. There will be the National Health Insurance as a regulator for payments on population that is covered by the National Health Insurance, which are normally the unemployed and or the civil service employees, and then there is another regulator for the private health insurance, which basically regulates everything else, which is probably going to be about 50% of the market share in a couple of years' time. Now, these two regulators, what they do is they regulate how payments happen for transactions that take place for the population. And then eventually, over time, what's going to happen is that these two bodies will come in as one body as soon as all the providers are independent providers, whether they are for-profit or non-for-profit. So that's going to be a probably 1 to 2 decades journey, and we're at the verge of that.
So just to clarify that, Mahmood, just so I understood this correctly, the intention in the medium term, and as you say, it could be 10, 20 years away, is that CNHI and CHI will merge?
No, they will work independently for a while, but then as soon as all the providers are accountable care organizations, whether they are for-profit or non-for-profit, then the point will come where the two will merge. Now, this is not written anywhere, but that's what my read of what's happening.
And the idea there that you nodded to is the fact that it's that point that was written in the original strategy of creating the clusters as accountable care organizations in each region, giving them financial independence, initially paid for directly through Ministry of Finance, but then ultimately paid for through CNHI, and then Health Holding Company, which is the body that's created them, stepping out of existence and leaving behind it a group of regional not-for-profit accountable care organisations consisting of primary care, social care, mental health, and acute care, which then become independent providers as part of a national insurance market. That's the ultimate aim. That's the nirvana we're aiming for at the end of the 20 years or so. Is that right?
Absolutely, absolutely. And hence the big mandates, the big problem that these clusters will have to address are, one is the capacity and demand. And so they have to find out how do they close that demand, the capacity demand gap. And the encouragement here is to close that through PPPs, through private sector agreements, through private sector participation. And that creates a tremendous opportunity for investment in Saudi Arabia, both locally as well as internationally. The second element is how to build a revenue cycle management system, whether you do that in-house or you get the Muhammad Eldars of the world to do that for you, or to do it on your behalf as a TPA. The third element is on engaging the clients in their health and making sure that they are responsible for part of their healthcare, whatever that they can participate with. And last but not least is the governance, both on the clinical as well as the financial side of things, and building the governance that enables each element of these so-called clusters to function at the top of their possible performance, but then collectively for the group to perform at highest possible levels. And so again, this is a roadmap that these clusters will have to pass through with passing through gate passes until they qualify to become an independent accountable care organization.
And it's not a short journey. Steve, you wanted to come in on this point.
Yeah, this is really exciting. I'm really curious to see where insurance companies go with this. At a recent digital health sort of award ceremony in Malta recently, there was a company in the UAE. I won't name them. I'm not getting paid by them, but it's an insurance model that where people get repaid their premiums for staying healthy, and they're attached to Fitbits, they're attached to wearables, and people get that reward. So I'm really curious to see how the insurance market is going to change itself as the infrastructure and the system changes in Saudi Arabia. How is it that we think about health insurance going to change over the next 10, 20 years? And then with that, if I think about the USA model with the health exchanges, having somebody there to independently run health exchanges, this is what Maximus does in the States. I think around 50% of all health exchanges or assessments like that in the States are run through a Maximus office. So it's really interesting to see about conflict-free, independent advice on where best to get health insurance from and where those services are provided. And then obviously the citizens' relationship with insurance, I think, is going to change drastically over the next 10, 20 years.
Ahmed, I mean, obviously you're the revenue cycle management expert. How do you think people's relationship with insurance will change as this system evolves?
First of all, I think at this stage, there is providers in sense of hospitals and polyclinics, and whom are maybe today doesn't have any sort of revenue generating out of those transactions, are very excited to see those transactions starting. And however, trying to create those I would say operations are sometimes because you have to have all the ready set people, process and technology in place in order to make sure that you have the right RCM in place to run it in-house. On the other way, I think on the other hand, when it comes to payers, insurance companies, they are a bit concerned about, the surge that they will face because of, today, maybe some cases are treated by charity, treated by the government, treated by different, payment method, but not definitely the health insurance today. So also those are to be taken by the underwriters and the health insurance companies to make sure that they will also, again, make sure that they have the right, I would say, pricing for those plans. The relationship is a mix between all of this, because as I think this is an excellent point, Steve. We usually, for example, in revenue cycle management, have one of the very important I would say pillars into the cycle, that is the insurance relationship management, where you have I believe that communication will make that easier. Planning in advance, along side by side or hand by hand, both together, communicating further what are the updates, so no surprises. So as a provider, you will be ready for example, if there are a set regulations in the country, but then you are not utilizing those for any revenue generation, then you are losing today. There are a couple of legislations already started, but they are not really activated in many institutions. And the other side, you'll find insurance companies doesn't want to have that sort of hit in one time. So let's phase it together. Let's talk about what could be done. I think it's a matter of communication. The relationship should be in at most. This is very important point in order to have a sustainable win-win situation for both parties.
I think there's an important point across the transformation of Saudi healthcare, which is how the relationship between private and public sector works. Because you've got a thriving private sector in place already. You're bringing in these publicly run not-for-profits that ultimately, are they competition? Are they going to sit alongside? I think all of this highlights how much of a big task Saudi Arabia has taken on with its healthcare transformation, and how much work there is still to do. But there's no doubting the ambition for it. I want to flip the conversation around a little bit now, and talk about Neom. We've talked about the public sector transformation. Let's talk about the biggest infrastructure project, not just in Saudi but in the entire world, and the way, Mahmoud, that you are tackling the question of the healthcare of your population. Mahmoud, if you could just start by giving, for those of you who aren't aware of Neom, if there are anybody living in a cave somewhere in Namibia that's not heard of it yet, do you want to just give us a very, very quick overview of what the Neom project is? Sure. And then we can talk a little bit about its healthcare system.
Sure. Well, basically, Neom is a redefinition of livability. It's a region of about 26,000 square kilometers, the size of close to Belgium. It sits in the crossroads of 3 different continents. It's as close as about 6 hours from 40% of the world destinations. It is one of the most beautiful land lots you would ever see, given that its nature. There is sea, desert, mountains, and little forest, if you like. And it's the hub for hundreds of civilizations, ancient civilizations, and so even that part of the history is there. And so this was selected to be the land lot for redefining how humans should live, with building at about 5% of the whole land and repairing nature in the remaining 95% of it. It's an ecosystem. It's not a city. It's not a project. It's more of an ecosystem that involves all the elements within a country. It is basically 3 main regions with sub-regions. The main region of it is the line, which is a unique way of looking at livability in a real estate, where you have 170 kilometers long city, 200 meters wide and 500 meters high. And so imagine if you're looking at Manhattan, for instance, and instead of putting the street 1, 2 through 20 or 46 or 55 next to each other, now you're putting them on top of each other. Now the idea is we're reducing any consumption of land lot in a way of repairing the relationship with nature and reinstating nature in the region. It is a project that relies heavily on renewable energy, and so minimal carbon and methane exertion. And that is the line. The line is basically a city that has every component of any city, the industrial side, the the commercial side, the little public entities within that, and so on and so forth. And then there is the southern region of Neom, which is Oxagon, which is basically an industrial city that half on the sea, half on the land. The third big region is Trojena, which is the mountains, where tourism in general and medical tourism as part of that is the area with a huge lake being built and a huge number of hotels being built around the lakes, and in an area that sees about 3 months of snow, and so skiing is going to be part of the tourism in Trojena. And then there are the little islands, the Shusha, the Sindala, Gulf of Aqaba, and so on. And these small islands are specific destinations for yachting, for high-end tourism, net worth individual owners, property ownerships, and so on and so forth. Now, if you look at this entire ecosystem, it is made up of regions that are basically real estate regions, and 15 sectors that constitute the economy of Neom. Health and well-being being one of them, biotech is one, food sector is one, water and energy, autonomous as in the digital services, and so on and so forth. And so these 15 sectors are basically the engines of the economy, and health being in the heart of all of that. As far as health and well-being is concerned, within Neom, we consider ourselves the basis of the economy, as we contribute to the economy by making people healthier and living longer, and by reducing sick days, and by reducing the otherwise potential expenditures on advanced healthcare had it not been prevented. And so this is the way that we contribute to the economy of Neom, and then each sector has its own contribution to the economy. The second contribution in the economy of Neom from health and well-being is generating jobs, and so bringing in the talents of the world. Neom is a global city, and it basically aspires on attracting best talents from across the globe. Even though it's a Saudi-owned and a Saudi pride project, it is a global project.
And ultimately, the ambition is to have 9 million people living at Neom and living within Neom. How are you going to look after the healthcare? What's the strategy for looking after the healthcare of those citizens?
Now, the overall strategy pillars are, one is it's a personalized preventative care, and so we keep everybody healthy, starting from the couple of thousand people that we have today, about 4,000 or 5,000 people, through the 60,000 people that do the construction work, all the way until we grow to 9 million people in 2055. And the idea is that personalized preventative care is one element, digitization and data utilization is another element. And on top of data, we use AI for recognition of risks. And so we tailor the individual's life and identify in the individual's life what are the potential risks that they could be exposed to, given the circumstances they live in, given their genome sequencing, given their personal differences. And so that includes their mental health, their age, their demographics, their genetic composition, their food consumption, in every aspect of a human being, including, and not only that, but also including the social determinants of potential diseases. Now, if you tailor that according to each individual's composition, you end up with 9 million different programs, if you like, for each individual individually. And we're at an advantage now that we have a very small population where we can start the system according to that, and then grow the system as the population grows. These are basically the two big pillars of the health and well-being: digital-based, digital twin-based, and proactive preventative. And then we also build for the rest of the world a, the research element of it, the medical schools element of it, the university side of it, and so on and so forth.
We've talked a lot about insurance models over the course of this conversation. How will Neom work from an insurance point of view? Is it going to be an insurance-based system? Is it going to be a government-based system? How will healthcare be paid for at Neom?
Well, Neom is basically a commercial ecosystem. So anything in Neom has to evolve around the IRR of a project or the return on investment. And so health is no different in that. And the idea here is that we would like to create a health insurance system that would enable the health sector and eventually the health holding company of Neom to provide to the strategy, i.e. in building the digital platform and in ensuring the effectiveness of the digital platform and the AI on top of it, on the preventative side of things, as well as on treatment, even when treatment is needed, because we know that not everything can be prevented. Now, if you look at the globe today, there are many health insurance companies that are evolving in a wonderful way, and you can see a lot of examples in the States, in Europe, in South Africa, of insurance companies that have moved away from the traditional reimbursement system for transactions to a preventative, proactive way. And what we're trying to build in Neom is a health insurance company that would be responsible for funding the digital stream and responsible for funding any preventative activities, whether it's from the client side, i.e. the Neom resident, or it's from the provider side, which is Neom Health. All of these activities need to be regulated as preventative activities. Their outcomes should be measurable, and whether it's on the short, medium, or long term. And then the reimbursement could be spread over time between reimbursements for things that can yield results immediately, intermediately, or on long term. Again, the payments will be done accordingly. The idea of the system is we're trying to build a non-for-profit yet private care system. The health insurance system is again going to be a non-for-profit to start with, and eventually be a for-profit healthcare system and for-profit health insurance system. Now, that health insurance system is only going to cover the basic benefit package, which basically should include anything that can be prevented and or be treated, but nothing related to aesthetics or nothing related to fancy services or additional services that one would require. And that's where the traditional insurance can kick in and be part of the payer system. Now, we see that in the beginning of Neom's life, until there is critical mass to allow for competition at a higher scale, we would assume that a single health insurance system and a single provider would be the way to go until the system grows to a critical mass that can allow the multiplicity of both payers and providers.
And is that the same system for providers? So are you also going to be looking at having initially a whole Neom provider system and then bring in other commercial entities?
That's the proposition. The proposition is that we start with a consortium of providers as the single provider. And so we have, people that run hospitals or primary care clinics or urgent care clinics or preventative activities come together as a consortium and provide this under one umbrella until, again, the critical mass is there to allow for multiplicity of providers or even spinning these services off as individual providers.
So what opportunities then are there for international suppliers, providers, insurers to get involved in the Neom project? Huge.
In fact, we're looking at the different insurance companies to see who would be interested in building the Neom specific health insurance system along with us. And of course, if we're to build that from scratch, it would be a huge loss until we get to a critical mass. Whereas if we build this along with an existing insurance company, then that is, the risk can be leveraged on both sides, and it can be much more viable and much faster. On the provider side, we again are looking at multiple providers today to see if we can create that consortium of the different expertise. So some of the partners within that consortium could be focusing on in-hospital care versus at-home care versus clinics care, and so on and so forth. And so again, we're in the process of incorporating the sector so that the sector becomes a responsible company with its own P&L sheet as a subsidiary of Neom, and then that subsidiary of Neom can go out to the market and look for partners in this joint venture that will hopefully take us from here until 2035, when the population is supposed to reach about 1 million, and then we open the door for a multiplicity of providers and payers.
So how does the development of Neom and the development of the health system in Neom relate or interact with the broader transformation program that we've been talking about in Saudi Arabia? What's the relationship between Neom and Neom's health system and the broader health system?
I guess the way base economy looks at Neom is more of a wet lab, and so whatever that succeeds in Neom would be a potential to copy paste to the rest of base economy. That is one way of doing it. The other way is if we manage to, and we're in the process of doing that, if we manage to build a digital platform, a unique digital platform, nothing like anything existing today, that takes all the individual data and have a layer of AI on top of that helps identify risks based on a disease index that is already embedded in the AI system. Now, that can be popularized in base economy. That system would need a huge amount of data.
I think broadly, everybody's excited about Neom. Everybody's curious, everybody's interested. And I think the two systems can learn from each other, certainly around models of care. It'll be interesting to see what happens in some very specific areas around mental health and around aged care, for example. What does the population of Neom is going to look like? How many of Neomians are going to be 65 and over, for example? And so that cross-fertilization of models of care and thinking and interventions and treatments. Neom University, we haven't had the opportunity to really talk about the aspirations of that. I think that's really exciting. Where's that going to go and take healthcare? So I think there's a lot in there to unpack. I think centering on the models of care and thinking about the systems of care that the public health system is trying to roll out over the next few years, looking at screenings, looking at NCDs, looking at cancer care, sharing of resources, sharing of knowledge is going to be critical. And I'd go beyond that. I'd go and say that Saudi Arabia is on a path to becoming a global leader in these areas. And I think the knowledge that is gained from the transformation program can be shared globally. And lots of people are going to be looking at Saudi Arabia, both individually as Neom and of the broader public health transformation program, and wanting to understand more and get involved, and for Saudi Arabia to export its knowledge and experience and its technology. I think our ability to be creative and innovative in medtech, for example, it'll be interesting to see where Health Holding Company, how does Health Holding Company integrate medtech into a lot of these new solutions? How much of that is going to come from Neom, and how much does that come from organic Saudis creating an ecosystem here that then is then taken abroad to other mature health markets? I think it's a very incredibly exciting sort of 3 to 5 year vision for where Saudi could be in this space.
I think probably goes even further than the 3 to 5 years. Certainly, if you look at the Neom project and how long, we've also talked about the integration of the public sector and probably taking 10 to 20 years as well. I think it's interesting, actually. Just I've been lucky enough to spend a little bit of time with Mahmood in the last couple of weeks and really get under the skin of some of the healthcare opportunities and developments at Neom. And in a flagrant plug, those of you who are at Global Health next week and are lucky enough to be able to get a ticket, on the Monday evening at Global Health at the Swedish Embassy, we'll be doing an event where I'll be interviewing Mahmood in depth about the development of healthcare at Neom. So if you're lucky enough to get a ticket to that, it should be very good fun. Jennifer, coming to you, I mean, the data opportunity with Neom, the intention of creating this individualized preventative care with every citizen having their healthcare kind of mapped to that degree. How exciting is that from your point of view?
It's incredibly exciting because it's so intentional, and that, and the opportunity to build data requirements that support overall goals rather than sort of muddling through what's expected within the system. And to go back to the conversations earlier about value-based care and so on, it's one thing to have the greenfield site that we've talked about in terms of Saudi Arabia overall in healthcare, but to have an intentionally planned system that provides you with opportunities to build this and to experiment with what can be done when you use technology to source data in the first place, to specify, the data from a range of different sources that can be used to build up ideas. And the thing that excites me about Neom is not just for Saudi Arabia and for the residents of Neom, but it provides opportunities for the rest of the world to learn about how you can design a system that meets the expected needs of the community overall. So the more people should be looking at this and realizing the potential for the rest of the world.
I mean, I guess it's an opportunity to see how the city of the future can work in every aspect, not just from healthcare in terms of kind of the way it works from a social point of view. It's a really fascinating project, isn't it? Mohammed, coming to you, just comment for us if you would on the, again, the revenue cycle management insurance element of this. How do you see what Mahmood said here developing? How do you think it's going to work in terms of attracting private sector insurers to get involved, creating that overall model of insurance for Neom?
I think it's a great opportunity for all sectors, not only the health insurance or the insurance sector, but it's for all, like having first ever an ecosystem that will work from as like a greenfield greenfield area from all angles. And I think, part of the change in healthcare is, for example, lifestyle. And having such a great sample like Neom to create all those new trends and new high-tech AI, digitalization, platforms, applications, the structure of the city itself, the way that you live there, like the close preventive medicine programs that you will provide, all those working together. I think it's extremely exciting to see all this working together and what could be the outcomes for that. I believe that the Saudi market is really still very attractive. The demand is still too high, so high. And I think, we have seen recently, for example, one of the largest health insurance specialized company entering to the market for the first time at that size just recently in 23, and that's like showing what could be the potential for such market. I believe, when you have the right I would say system when it comes with prevention, costing, having the right transactions, having the right patient experience, good lifestyle. I mean, blending all this together will give us, I'm sure it will give us an excellent results. I look really forward to seeing, next at least 2 to 3 years, the outcome of at least the first initial steps of something like what's happening today in Neom, and I'm sure many others are still also, you know, like having the same thing. That we are all looking for this, as this is like a very new, the latest, I would say, ecosystem that we could look at, as that, you know, like all the efforts and resources are invested into one area.
Gerard, it's sometimes a bit of a strange thing to talk about legal and regulatory issues. It's exciting, but what excites you about the opportunity to get the kind of legal and regulatory elements right for something like Neom and Saudi more broadly?
So, look, going back to the start, it's really rare. I mean, it's a once in a generation thing. In fact, it's even probably once in a century thing as a lawyer to get an opportunity to actually create something from, you know, from the beginning, and to be able to write the laws, because often we've got so much already established that you're already trying to work through things to turn them into what you want. Whereas with Neom, you don't have that. So it's very much about looking at how do you create a system which is focused on an individual, which is focused on personalized care, which we've never done before. We normally look at the mass provision, and make sure that within that, your legal system and the use of data incentivizes the individual to engage with it and to actually think about, you know, their obligation to look after themselves as much as anything else. So that's the way you're doing it. And it's, I mean, Steve spoke briefly and mentioned briefly about mental health law. The mental health laws are being written there. It's an important part to make sure that people who are suffering from mental health issues are looked after and are cared for. And I think within that, what you will start to see, and what we are, you know, I'll unashamedly say here now, is we look at what we've been doing in Neom and we use that in what we're doing in the UK. So, you know, we work with, you know, the UK regulators in terms of what regulations they're putting in place in the laws, and we use that there. And we use it, you know, when we're talking to other organizations around the world that are doing global work too. So it is, as Mahmoud said, a wet lab at the minute, but I think not just for Saudi Arabia, but also actually for the whole world to look at how can you create this personalized health system. And a number, you know, huge numbers of people are interested. People, you know, to some degree know we've done some work over it, and they want to know, what does it all mean? How does it all work? So I think all you will see is more and more interest in it, and hopefully that will drive the interest of, you know, the insurers, the healthcare providers, but a whole range of other people, so that, you know, we really see the benefits of what can come out of Neom.
So we've only got a couple of minutes left, which is a real shame, because I think we could carry on talking about this stuff for hours. I'm going to give the last word here to Mahmoud. As the man who spans both public and private sector in Saudi Arabia, what do you think are the key challenges, the key issues that need to be dealt with immediately in order to make sure that both the public and private sector transformations in Saudi are gotten right? What are the things that you need to think about? And it's that one time in a conversation when the mute button gets in the way. There we go. You're back. You're on. We can hear you.
I guess again, Steve and everybody, that the key in all of this is the human factor. The key is having the right talent in place. And I think we've been training people in their pigeonhole areas forever. Now we need to implement the notion of cross-industrial learning. And so based on that, we're redesigning medical schools, we're reshaping healthcare schools so that the products would come out not only knowing their own pigeonhole area, but across understanding the whole industry across. And that is my introduction to what we're doing with Neom University on the healthcare schools. But we're also doing that with base economy medical schools as well, as in King Saud University, changing how the product would be out of these schools. Some of them would be data scientists, along with being a physician and or a nurse or a technologist. Some of them should be and as I said, in data management. Some should be in system management. Some should be in finance and economics. Some should be in IT and informatics and so on and so forth. And the idea here is to bring in healthcare providers to run a healthcare system. You get a financial and a digital disaster. To get a non-healthcare provider running a healthcare system, you lose or you don't know the intricacies of the healthcare provision. And so another type of disasters happen. And so developing the right talent that would lead this system would be in the prime focus of the change that should take place.
And the building of a sustainable workforce, I think, is key to any health system anywhere in the world. And it's a great place to finish. We're out of time, unfortunately. It's been a fantastic debate. I'm sure there will be much more discussion next week at Global Health out in Riyadh. If any of you in our audience are going to be in Riyadh next week, please do reach out to me. It'd be great to have conversations. It'd be great to meet up. We have a huge program of stuff happening in Riyadh next week. Should be fabulous. It's been a great conversation this morning. I want to thank Gerard, Mohammed, Steve, Jennifer, and of course Mahmood for a fantastic debate. This has been the Healthcare World Series. It's been great to have you along, and we'll see you all again very soon. Thank you very much. Goodbye.